Good afternoon, everybody. I want to welcome you to iWorld's Corporate Education for Saturday. We're going to be speaking about products from ZEISS. With me today is Stephen Dell from Austin, Audrey, Talley, Rostov from the great city of Seattle. And we don't have Bill Wiley yet from Cleveland, but Bill will be joining us. We're going to go over several things today. We are going to have an audience response system. So if you want to do the QR code, I'll leave it up here for a second. Certainly feel free to ask questions. I don't know if this is going to come up again, but Jim, sitting right here at the front, can help with any questions. And certainly if you want to go to the mic at some point, you can do that as well. So this is our disclaimer. I know I'm going to let you guys read it real fast. Okay, I'm going to share a little bit of experience with the MEL 90 Excimer laser, which we were involved in the FDA clinical trials. This laser obviously is fast and it's really, I think, state of the art. In the United States, the tracking system is twice that of the hertz rate of the laser. The laser is operating at 500 hertz, treating about 1.3 seconds per diopter at a 6 millimeter optical zone. The great thing about the laser, it has AAA, which is compensation for cosine effect, minimizing spherical aberration, decreasing astigmatism regression over time. The one thing I will say about the laser is small footprint, very stable interaction. We've used the MEL 80 for over 20 years, and in that time period, maybe once every 7 or 8 years, we had a day where we couldn't operate, but incredibly stable device. And then the support, which I think the other folks on the panel will say, the support from ZEISS, both in an engineer standpoint and their technician that comes on board to train your staff, called a refractive account manager. They're just best in class, just really strong folks. So let's look at the FDA report. The treatment for the MEL 90 is up to 10 diopters of myopia, spherical equivalent at 10 diopters, and treating up to 4 diopters of cylinder. Hyperopia up to 4 diopters of sphere, and a spherical equivalent up to 5. Max cylinder treatment is 3 diopters, and greatly mixed astigmatism was also approved, treating up to 4 diopters of mixed astigmatism. This was approved for patients age 18 or older, and obviously the normal stability we want to see in a yearly time frame prior to surgery. Looking at data from the study, effectiveness, stability, we'll talk about, and then safety for the patients involved in the study. So this was a very large study. I saw a recent approval, and the approval was only for about 300 eyes. This was 714 eyes, almost 360 myopic eyes, 220 hyperopic eyes, and 135 mixed astigmatic eyes. The astigmatism average was about a diopter for the hyperopia and myopia, and then for the mixed astig was average was 2.75, so large amounts of astigmatism. If we look at the results, slide left, for the myopia, 94% of that cohort was reaching 20/20 uncorrected distance vision. This is with no nomogram whatsoever for any of these cohorts, the myopia, hyperopia, or the mixed astigmatism. The hyperopic 2020 was 73%. And the mixed astigmatism was 81%. So these are really good results. I think they only get better once you get it in your house and you're following your patients with outcome software. As we look at the scatter plot, really good across the board. The myopia is in gold. Hyperopic is in purple, and the mixed, I stand corrected. Hyperopic is in green, and the mixed is in purple. So again, across the board, if you look at lower right, the confirmed lower cylinder myopia group, getting plus or minus a half, 96% of the eyes. So really tight corrections for the cylinder corrections, even on the low end. As far as the PROW questionnaire, 98% of patients or thereabouts were satisfied, very satisfied, or completely satisfied with the results. So really good reports from patients. And if we look at induction of symptoms, the blue is if they had any report of negative, and the circles you see were very or extremely bothersome. So all of them were less than 1%, except for Starburst, which was 1.8%. And this is really strong work for any type of corneal refractive surgery, having that low of induction of unwanted symptoms. As far as the treatment range, it's really a large amount. I can't think of many people in the United States or even outside that are going to treat patients greater than the range that's available with the MEL 90. In yellow is the MEL 80. The MEL 90 is expanded beyond that, again, treating the full range myopia, hyperopia, and the mixed astigmats. We compare this to other systems that are available in the U.S., looking at ZEISS, Alcon EX500, the B&L Teneo, the Star S4. It's really across the board really good. And as far as the ablation speed, the ZEISS is right there with the other systems running at 500 hertz. So you're really going to be able to treat literally any patient that walks through the door that's an appropriate candidate.
Yeah, so my journey is that I was a wavefront guided user for many, many years, a VisX user for decades, literally, and performed several of their clinical trials in the early years. Saw that platform coming to the end of its useful life, and it was experiencing increasing problems with reliability, with downtime, with replacement part difficulties. And it was clear, the writing was on the wall, that was a platform that was reaching the end of its life, even though we received really good results with it. But I'd been indoctrinated into this way of thinking that wavefront guided treatments were really very, very important for high visual quality. And so when I switched over to the MEL 80 some time ago, I kept looking for a signal that there was some inferiority in the quality of vision, and I never found it. I found that these patients were doing extremely well with the MEL 80. There were some annoyances with the MEL 80 because there is a somewhat limited treatment range, as Dr. Doane pointed out. That all went away with the MEL 90 because we have a very broad treatment range. And sometimes I would have to double card with the MEL 80, and that's just not an issue with the MEL 90. Another issue that became somewhat poignant, especially during COVID, was the availability of gases especially for the VisX. And having a low gas consumption laser like the MEL 90 was really very valuable to me as a single laser owner. We only have one Excimer laser. So I also was pleased to see how tissue sparing the laser is. Our clinical results have been great. And the only thing that I can add is that the fixation target, you mentioned the Heenies for seeing where the spots are. That's kind of nice. But the patient fixation target is, I think it may be one of the best of any Excimer that I've used. And that's very helpful for the patient's peace of mind on how they're doing during the procedure.
On that note, remind me, I think you mentioned some patients you've talked about with the 80 that patients are looking around, and I think you had some discussions with patients under the 90 looking for the fixation beam. Do you remember our discussions on that?
Yeah, I mean, with the 80, we used to tell them to look into the center of the ring of lights as opposed to the fixation target, because the ring illuminator was so bright that it sort of drowned out their ability to even see the fixation target. And with the 90, that has been significantly easier.
I just want to add, I also was a big VisX user for years until it basically died. Mm-hmm. And then it was a good workhorse. It was a great laser. And then in my previous practice, I had the EX500, also a very good laser. But in my new practice, I'm getting the, MEL 90, and just with the demos of, deciding I could get whatever Excimer I wanted to. I do consult for all of the different companies, by the way. So what I decided is that the friendliness in terms of a user interface of the MEL 90, one of the things that I found with the EX500 was that sometimes it was a little bit tricky to know if you're plus cylinder, minus cylinder, and to kind of double check. I found that some of that user interface, at least for me and my staff, you just have to be, you're always super careful. But I think it's a little bit more friendly, at least to me, with the MEL 90. And also I would say that the fixation targets are also very user-friendly for the patient.
Yeah, and for those of us who are big believers in wavefront guided, or maybe you're even thinking about a topo guided or a ray tracing guided treatment, I would throw out this concept to you. So let's say that you could create a laser solution, a laser pattern that perfectly compensated for the wavefront error of your patient. or for the topography error of your patient perfectly, and you delivered that treatment with perfect centration. Well, let's fast forward 6 months down the road. Let's perform an epithelial map and look at the epithelium compared to the preoperative epithelium. Do you think it will have changed? Of course, it will have changed quite dramatically. And there will be a completely new constellation of higher order aberrations that are now present. So your perfectly tailored treatment is now perfectly tailored for the wrong thing. So I sort of understand why wavefront guided and topo guided treatments were developed, but to me, the rationale for a very, very efficient wavefront optimized treatment like we see with the MEL 90 makes a lot of sense. This is a case that we did just on Wednesday. This is a kind of a somewhat nervous individual, a 26-year-old male. We work in minus cylinder, so I could, that, you know, if you were, you know, it's important to get the plus and the minuses right. This individual could have had SMILE, and frankly, I think I maybe normally would have done SMILE on him, but he really wanted LASIK for some reason. His family members had LASIK, and that's what he wanted, and he was a candidate for either one. And I think I can maybe show this video here. All right, so here he is, and we've marked this individual. He's a high astigmatism person, and we're just getting lined up here. Fixation target is really easy for him to see, and as John pointed out, you can see the ablation pattern really, really well. So okay, yay, we did it. Okay, let's go to the, can I advance that?
So back to a few things. The one thing, we're going to go through some questions here. And Audrey, you kind of hit this on the graphic user interface. We had a meeting a week or so ago about what we're going to talk about today. And one of the questions came up on the graphic user interface of the screen in front of you, especially for a technician that is entering the data. And the concern was, I think somebody had the plus and the minus and you're confusing the convention. And I went back and looked at the 90 versus the 80. The 90 is very clear to read. I mean, it's either a massive plus sign or a massive minus sign. So I think the likelihood of a doctor or a technician confusing the convention should be near zero with that user interface. You want to tackle any one of these topics, Audrey, as far as treatment speed or platform? Have at it.
Yeah, I mean, I think that I'm looking forward to now having my new MEL 90. The fast treatments, of course, we've gotten, now used to the faster treatments, and that's great. And what I guess I really like about it is that it's very intuitive. So I like the fact that even though it's, designed by German engineers, which are amazing, it's still intuitive. Easy to use, and especially with the graphic user interface, I think is just one of the highlights for me, as well as the full range of treatment.
Mm-hmm. One thing I was going to mention from a technician standpoint, we've been using the ZEISS technology now for 20 odd years, and ophthalmologists tend to be OCD, but interestingly, ophthalmic technicians tend to be OCD. And so one of ours she was always kind of complaining about certain positioning on the MEL 80, working with the computer screen. That all has gone away with the MEL 90. She's really, really happy with her ability to do input, changing on the fly. So I want to be happy. I want to be happy with the laser, but I also want our staff to be happy with the laser. If they're happy with it, it just makes for a much more comfortable day. As far as the full range of treatments, this laser does, I think, anything you would want to do from a laser vision correction standpoint. There were the days in the past where an excimer laser would go to, 20 diopters of myopia. Well, we know we're not doing that anymore. So if you're doing a max of 10, a large amount of astigmatism and treating some level of hyperopia, and importantly for me, treating mixed astigmatism, I think mixed astigmatism works so well with this system that literally there's not a patient that would walk in that I could not treat in that situation.
This is an important point, John, because those of us who've done clinical trials for Excimers, filling the bins of mixed astigmats was always the most challenging. It's hard to find these people, but a reasonable number of my laser vision correction cases are enhancements of IOL patients. And very large percentage of those are mixed because you've probably hit your refractive spherical equivalent target, but maybe there's some astigmatism, or you're close to your refractive spherical equivalent target. And having a laser that's really good at mixed is really important to me. It was one of the key criteria for me to select a platform.
Mm-hmm. On that point, as far as mixed astigmatism, with both the MEL 80 and the MEL 90, in my experiences, there literally is no nomogram. I mean, whatever I refract is what I enter in the laser, and it literally is spot on from that standpoint. So literally no nomogram whatsoever. Audrey, you want to grab anything else here and talk about? Bill, glad to have you.
Yeah, I'll jump onto that. We also are not using a nomogram, which was it was almost the first day we went to the 90. The lead tech, who typically does most of our calculations for review, put this list of patients that we were going to treat, and then she sort of said, "There's nothing to review. We just type in what is the refraction." And it was a little bit of a shock, but yes, that's exactly what we do.
I guess I like the availability of, as a refractive surgeon, I offer just a full array of whatever the patient needs. And most of my either LASIK, or I do very little PRK actually, is a lot of mixed astigmatism, and of course for some of the hyperopes, but I tend to do, although I offer all of the treatments and try to match it best for what the patient needs, it's nice to be able to have a reliable, an option basically for patients, especially those with the mixed astigmatism. Also, a lot of those are the enhancement, just as in your practice as well.
What was your experience with VisX, since you used that platform for a long time, with hyperopes, with the VisX, and with mixed in the VisX?
The mixed was okay, but the hyperopes not so much. And so the VisX, which I used for years and years, it was really not great for hyperopes. And so I tended really not to do that for hyperopes, or to just for really, really low amounts of hyperopia, more towards the mixed astigmatism, because I didn't find that the VisX platform was ideal for that, at least my experience in my hands.
Hey, Bill, we'll get you in on this. I know, Bill, you've used a lot of lasers over the years. Can you share your experience with it, MEL 80, I think you're getting the 90 very soon, in other systems, and maybe from a outcomes, reliability, engineering, and technicians coming in to help?
Yeah, I think we were involved with the MEL 90 in the study, and was really impressed with just the efficiency and the sort of intuitive nature of working with it. We filled up, anytime you do a study, if you're getting good results, it's that much easier to kind of fill that study. And we filled up just within weeks, to fill up the patients that we had a couple of staff members that had the treatment. They told others, they told friends. So it was very quickly realized that this was our best laser platform that we had on site. And it was a preferable laser platform, but we could only use it for study patients. Some things that I was impressed in, and you talked about hyperopia, some of the things like visual alignment, some of the other platforms are a little harder to have that centration. Maybe it's tracking pupil, the way it identifies the visual axis. And I don't remember the exact nuances. It's been just a little bit, but I just remember the MEL 90 was very intuitive of identifying the visual axis, so that you can make sure you have that treatment placed on the visual axis. You could maybe be tracking pupil, but if you're not put on the visual axis, particularly with a hyperopic treatment, you're just not going to have those results, or those mixed astigmatism. And I think that's one of the testaments why they were able to be approved for such a wide range of treatments out of the box, because some of those things of how you're able to translate the treatment out of the cornea and assure it's on that visual axis.
Yeah, that is a good point. I noticed that the tracker when it engages, it has locked on before I can even think about it. It's almost instantaneous, which certainly was not the case with some other platforms.
Yes. Great. I think we're going to go ahead and move on. Hey, we do have a question. This is from Anonymous. How tissue sparing is the MEL 90? I'll just give you my thoughts. We do most of our treatments at a 6 millimeter optical zone, and the short axis of the astigmatic treatment is very large. I think I typically calculate about 14 microns per diopter, which is, I think, a good place to be going across the entire range. Anybody else want to comment on?
Well, do you typically default to a 6.0 optical zone, or do you a lot?
I do 6.0. I'm okay with doing 6.5, and I think in the optical zones you can go, if I remember right, by 0.1 increments, so 6, 6.1, 6.2, all the way up to 7.
Yeah, and we actually did, adjust our optical zone a few times throughout the study. And it's interesting. A lot of times you worry that adjusting the optical zone is going to adjust that nomogram. But like you all, we basically treat the prescription, and somehow the treatment program is sort of intuitively knows when you're adjusting that optical zone, it's going to adjust the treatment pattern. So you don't have these variable nomograms. I think that happens with a lot of other platforms. You're afraid to deviate from one optical zone, but you're afraid it's going to affect your nomogram. With this seems to be very robust, across a wide range of optical zones.
Great.